Okay, good morning, students. Yesterday, we were talking about the hepatitis A, hepatitis B to some extent, and we are dealing with laboratory diagnosis. That is where we have stopped yesterday. Today, to continue the class, laboratory diagnosis of hepatitis B virus depends upon the demonstration of serological viral markers. So that is important, and you should know the timeline as to when each and everything appears. Yesterday we started about hepatitis B surface antigen represented by the word HBsAg. Please remember, it is the first marker to appear in the blood after infection by HBV. And it raises even before the transaminases, that is the liver enzymes and clinical enzymes like jaundice. And it remains in circulation throughout the phase of jaundice and symptomatic course of the disease. And disappears within 2 months, or at times may prolong up to 6 months or even beyond, but usually 2 months. And when this starts disappearing, the anti-HBsAg antibody that appears, and that is protective. As I told you, we are happy to have an antigen which stimulates the production of antibodies which are protective in nature, because we can make a vaccine out of it. Next, after hepatitis B surface antigen, hepatitis B core antigen, HBsAg. This is not demonstrated in blood because it is present inside HBsAg protein. So hepatitis B surface antigen coat is there, and when the coat is there, you don't see the HBsAg in circulation. But what do you see in circulation? The antibodies to HBc core antigen. So anti-HBc antibody appears within a week or two after appearance of the hepatitis B surface antigen. So now there is another PGI construct, earliest antibody, to appear long before anti-HBe or anti-HBs. Remains positive lifelong. See, there are 3 important things. Not only it is the earliest antibody, before anti-HBe it occurs, and before anti-HBs it occurs, and also lifelong it is there. Okay, so not only it is useful as a first antibody to appear, but also useful indicator of earlier infection with hepatitis B virus, even after all the markers are undetectable. That is the most important. Okay, as usual, the IgM usually is the predominant one during the early phase and late phase. IgG, about 6 months, it is IgG. Distinction between recent and remote infection. Recent in case of IgM and remote in case of IgG. Now, coming to HBe antigen, E for in blood, appears concurrently in blood with hepatitis B surface antigen. So, HBsAg and HBeAg, they appear simultaneously. Circulating HBe, if you have seen HBe antigen in the circulation, it is indicative of the viral replication, presence of DNA polymerase, and the DNA of HBV, virions in blood, indicates high infectivity of hepatitis B virus. So please remember, circulating HBe antigen is of value because it shows there is a presence of DNA polymerase, HBV DNA, blood virions, and viral replication is actively going. So, highly infectiveness. Disappearance of HBeAg coincides with fall of transaminases. The liver enzymes will fall as soon as the anti-HBe, as soon as the HBeAg disappears from the blood. So appearance of anti-HBe follows, that is anti-HBe antibodies, and absence of hepatitis B E antigen and presence of anti-HBE, that is antibody, which means low infectivity. These are all important figures you have to remember, words that you have to remember, both the figure and both the words, because in interpretation of a result, these are all important. So this is the one which we were discussing about. The red line is about HBsAg and anti-HBs antibody, and the blue line is about HBeAg and anti-HBe, and the dotted red line, HBcAg, will not appear in the blood because of the HBsAg code, and anti-HBc antibody is there, and we can detect it. And also we have discussed the importance of various other parameters, and now I tell you again to master this figure, because you can write a very descriptive essay of the laboratory diagnosis once you remember this figure properly. So, interpretation of viral markers in the blood. If you see HBsAg, it is acute HBV infection. IgM and anti-HBc, recent infection. IgG and anti-HBc antibody, remote infection. And rarely, true low hepatitis B surface antigen. IgM, anti-HBc. These are the two things that may occur. And HBeAg, relative high infectivity. Anti-HBe, antibody low infectivity. And anti-HBe also may be there where chronic infection and in carriers. And only anti-HBsAg and no other marker. Please mark my words. Only anti-HBsAg and no other marker means vaccination. Why? Because we are using only hepatitis B surface antigen as the vaccine producer. Okay? And apart from that, you have a whole genome vaccine also that we'll see later. So there are two tabular columns in the text which we follow. Right? One is the markers and other is the interpreters. What I did yesterday is I brought them two into the same slide. That is much useful. Just like what we have discussed. Suppose a given situation is given as the serological markers and then the interpreters. Both are side by side. We can see them. So HBsAg plus, HBeAg plus, and IgM is there, and there is no anti-HBs antibody and no anti-HB antibody. That means acute HBV infection, highly infectious. Suppose HBsAg and HBs are present, IgG is present, no anti-HBs or no anti-HBe. Later, chronic HBV infection, it is a carrier state. Suppose HBsAg is present, but HBeAg is absent, IgG is present, and anti-hepatitis B surface antigen is also absent, but anti-HBe is maybe present or maybe still absent. Then it is a late chronic hepatitis B surface infection with low infectivity. Okay. Earlier it is highly infectious, but later it is not that highly infectious. It is low infectivity. And if you see both hepatitis B surface antigen and hepatitis B E antigen, that may be there or may not be there. IgM is present. And no anti-HBs, anti-HBe may or may not be present. And seen relatively or rarely in early acute HBV infection, still infectious. And you have not seen either hepatitis B surface antigen or HBe antigen, but IgG is present. Anti-HBe antibody, anti-HBs antibody may be positive or may be negative, which means a remote hepatitis B infection, infectivity nil or very low. Remember, the hepatitis B surface antigen and HBe antigen are not same, means infectivity is less. And whether the presence of anti-HBs and anti-HBe antibody is there or not is the real issue. If antibodies are present, definitely the infectivity is very minimal, or nil. And as you have seen, only anti-HBs antibody is present. No other markers. It is indicative of the process of vaccination. So, this is what actually explained in the various tablet columns and also the graph. HBEG and HBV DNA, they indicate active replication of the virus. So, if you detect in the serum sample HBEG, that is blood, also free HBV DNA are able to detect and HBE antigen are able to detect. It is either very early stage, infectivity is there, highly infective, degree of replication also is there, and what does it indicate? It's relative prognosis. But today you have assessed the viral load about HBV DNA. It is 10,000 copies. Next it is only 5,000 copies. That means your medication is working, your vaccine is working. So like that, you can think of it is a prognostic indicator of your line of treatment. And also molecular methods like DNA hybridization, because you have a DNA polymerase, this PCR can go and it is used and highly sensitive and quantitative also. It is not only qualitative but also quantitative. And HBV DNA level in serum reflects the degree of viral replication in the liver. As I told you, serial estimations of viral load will show you that a decreasing viral load is good prognosis. So, useful to assess prognosis. And in chronic hepatitis or antiviral chemotherapy, these are the sheet anchors that guide you about the appropriateness of the treatment. And what about prophylaxis? General prophylaxis avoid risky practices, that is, promiscuous sex. That is, you don't have multiple partners and unprotected sex, and injectable drug abuse, that is, like sharing heroin and all these things, and direct or indirect contact with blood and semen and other body fluids. Okay, you know, suppose you are delivering a woman, then also there will be a splash of the fluids, which are maybe hepatitis B positive. So, and semen donation, it can be present not only in semen, other body fluids also. So, it is very important. And health education regarding safe injection policy, that is, don't use syringes, use of disposable syringes and needles only. Other measures like screening of blood and semen and organ donors is very important. Suppose the kidney is being donated as a bonus, hepatitis B virus also may enter the body. So please examine and screen the organ donation with HBV in blood and body fluids. Still precautions also must be taken. Immunization, the best, the only certain method is universal immunization. Universal immunization. Both passive and active, they are available. Passive immunization means pooled hyperimmune hepatitis B immunoglobulin, HBIG, from human volunteers with high titer of anti-HBs AG antibody. Okay. And the dose is 300 to 500 international units soon after exposure to infection. Protection may not prevent the infection. It may not prevent the infection, but it protects against illness and carrier state. That is the reason why you should go for passive immunization. And active immunization, either you suffer from the disease or you take vaccine. So history, if you say, first vaccine is prepared in 1982, pooled human plasma, from healthy carriers only it is taken, but with high antigenemia, it is discarded because of human source. You are not only taking hepatitis B surface antigen, and other antigens also may be there. So risk of unknown pathogens of transmission. Number 2, because Manishini Juchundaite, number 2, because he might or she might transmit other disease causing agents also. Now, HPV vaccine, how we use it? It is a genetically engineered vaccine cloning the S gene in Baker's yeast. So we have seen what is this S gene is responsible for hepatitis B surface antigen. So that is in Baker's yeast contains non-glycosylated hepatitis B surface antigen particles alone and given with alum adjuvant. Adjuvant can be a short-term question. It increases the immunogenicity of an immunogen. That's what the definition of adjuvant is there. Okay, it's a different issue. Again, chemical, all these things you have. So adjuvant is a short-term question. So alum, that is aluminum phosphate adjuvant is used. And site adults, deltoid, and infants anterolateral aspect of them. Usually, people prefer taking in the gluteal region. But here, you say it is deltoid, adults deltoid, infants, anterolateral aspect of them. Gluteal injection is not recommended. Why? Poor response. So dosage, 3 doses. First is at 0, next 1 month, next 6 months. Of course, a special vaccine is available, including all the antigenic components of hepatitis B surface antigen. Pre-S1, pre-S2, and S. The special vaccine, what is the special advantage of using the special vaccine? It is manufactured in India, low cost. It is in the national immunization schedule and all. So it gives better seroconversion. What is seroconversion? That is by testing for anti-HBs antibody, estimation of anti-HBs antibody undetectable up to 5 years. So this is the seroconversion that we are expecting. Clinical production is much longer than 5 years, but serologically it is detectable up to 5 years, the anti-HBs antibody. Booster doses for high-risk groups of weapons, the healthcare workers, all the healthcare professionals should receive a booster once in 5 years. And special vaccine, that is the pre-S and hepatitis B surface antigen and pre-S2, all these things that they are there, it is giving rise to a better seroconversion rate. And combined immunization, there is active and passive both. Yes, babies born to carrier mothers, they have to do 0.5 milligram, 0.5 ml of pooled hepatitis B immunoglobulin, single intramuscular injection immediately after birth, followed by full course of the vaccine. Of course, at a different anatomies. First dose of vaccine, 12 hours after birth should be given. If, for example, the hepatitis B immunoglobulin is not available, what to do? Will we wait for it? No. Just give the active immunization. Vaccine given alone also gives protection. Then why HBAG you may ask? If it is available, you better do it. If it's not available, don't wait waiting. Just give. Even the vaccine itself is okay. And the mother's milk will definitely give protection towards the other diseases that are there. Coming to treatment, there is actually no specific antiviral, acute HBV infection. Interferon alpha, interferons, they are the agents produced by our own body against virus, so they can be of help. And antivirals such as lamivudine, absectobacter, beneficial in some cases of chronic hepatitis. Carriers, no effective treatment for carriers. Spontaneous resolution is also in some cases. Now that is about hepatitis B. And now let us see about hepatitis C. Identified during studies of non-A, non-B hepatitis. Most common cause of post-transfusion hepatitis in development. So, you are urgently requiring some blood for some cesarean or some anemia or something like that, and without proper screening, taking the blood, and what if the get is hepatitis? It is mistaken to be a different type of hepatitis, but earlier they called it NANB. Now they know it is because of type C. Clinical features, incubation period is about a long one, 15 to 160 days. That is 2 weeks to all around 5 months or a bit more. So with a mean of 50 days, so 1.5 months. Acute illness, usually mild and anecdotal. So that is what differentiates. Jaundice you find in hepatitis B or A, but C, very mild 20%, and it may be without jaundice. So over jaundice is in only 5% of cases. An important part of HCV is the chronicity of the illness. So you remember, just like the incubation period, it is very chronic. 50 to 80% progress to a chronic hepatitis. Some develop cirrhosis and even cancer. It is a cellular carcinoma. Epidemiology, okay, it's a bit of a community medicine topic, but still we will just see the outlines. As we said, a large number of carriers, estimated to be 200 million all over the world. At present, India, 12.5 million cases, or even more, because at the time of preparation of this PowerPoint, now it may differ from 12.5 to slightly increase. Hepatitis C and hepatitis B, they have certain similarities. They resemble type B epidemiology. Hepatitis C epidemiologically remembers type B. And infection is mainly due to blood transfusion or products of blood. Other modes of contact of infected blood are blood products. Okay, so by injectable needle, so injectable drug users, wrong usage of unsterile syringes, definitely. And one more, with the increase of technology, transplant recipients and immunocompromised patients, they are at high risk. Less important is sexually transmitted disease. Okay, so this is also a factor, but less important. And from mother to child also may take place. And infection and carrier rate throughout the world, with the carrier rate varying from 1 to 20%. Why? Depending upon the precautions taken, they vary from 1 to 20%. And coming to prevalence, it is prevalent in India with about 12.5 million cases. So, an estimate with a guess is a guesstimate. Quarter of all chronic hepatitis in India are believed to be due to HCV. So, the HDV, not only HBV, but HCV also, it is causing considerable hepatitis cases. So, morphology, it is like this. You can see the envelope and also the spike-like structures and the central RNA, because hepatitis B is only the DNA and the rest of all are RNA. So, culture not grown outside, cloned with Escherichia coli, 50 to 60 nanometer size, and single stranded RNA linear genome, enclosed in a core, surrounded by enveloped with glycoprotein spikes, just like the COVID, you have spikes here also. And it resembles flavivirus in structure and organization. So, the genus is Hepatitis C virus, that is hepatitis C virus, family Flaviviridae. There is a considerable diversity, genetically and antigenically, 6 different genotypes and as many subtypes. High mutability is indicated. Why you are unhappy with high mutability? Anyway, if the virus is highly mutable, we are definitely unhappy. Why? Because it is difficult to prepare a vaccine. Once you prepare a vaccine, another mutant is coming. So, high mutability is not a very happy feature for man, because preparation of vaccine will be difficult. So, distribution, some genotypes are worldwide, some are localized. And this is the reason why no immunity is there, because of this diversity. There is little, which means no or very little, heterologous or even homologous post-infection immunity to hepatitis C. So, any number of transfusions you take, still you will be susceptible to hepatitis C virus. In fact, more number of transfusions, more chances of HCV because each time you get a different mutant. Laboratory diagnosis of HCV, ELISA is there. You can detect the antigen because the HCV clone essential polyp is there. Sensitivity and specificity. It is difficult to have a highly sensitive and highly specific test. But currently, third generation ELISA is in use, employing the NS5 region proteins and synthetic peptides. Becomes positive only months after the infection. Shows non-specific reactions. What do you call such a test? Limited diagnostic utility. Because you immediately need to treat, and you are at a difficult situation where only after months you know the diagnosis. Yes or no? So, usefulness is limited of diagnostic utility. Culture is not yet established outside the human body. Confirmation is by immunoblot assay. Antibody appears late, irregularly, limiting the diagnostic utility. And HCV RNA in blood as identification, it is more sensitive and specific within a few days after HCV. So, if you detect HCV RNA by the PCR, it is definitely an indication of the diagnosis. And molecular methods, PCR and branch DNA assay, Artsbody, can be done. Coming to treatment and the prophylaxis, general prophylaxis, you should take, sorry for the spelling mistake, general prophylaxis, that X is extra. Screening of blood donors for HCV is important, and no active vaccine or passive immunization is available. So, better be careful while you are administering the blood. You screen not only for HCV, you screen for HCV also. Prolonged treatment is required. Interferon alpha alone can protect you, or in combination with other antivirals like ribavirin, useful in some cases. So, depend on interferon alpha only, ribavirin, maybe some cases it will be useful. Now, let us talk something about hepatitis D virus. It is important because D stands for deficient virus, D stands for delta virus, D stands for depending upon something else. Suppose something like I am very strong and a person who is very weak wants to beat me. This is a constant example I give. So, you then take the help of some other strong person and then beat him. So, you depend on somebody. That is this depending virus. What does it depend upon? It depends on hepatitis B virus. Unless there is a co-infection of hepatitis B virus, there is no possibility of hepatitis B virus infection. So, 1977, Rigetto et al. In Italy, they have discovered universal nuclei. Patients infected with hepatitis B virus, some hepatotrophic delta named as HDV. Earlier, they used to think that adenoma is a part of it, but now they know that it is not adenoma. It's a delta, is a defective RNA virus dependent upon the helper function of HDV for its replication and expansion. Survival, no independent existence, only as long as hepatitis B virus infection persists in the host, HDV survives and replicates. So also, this point you remember, if one person gets properly vaccinated for hepatitis B, there is no question of hepatitis B occurring. Okay, so please remember, it is not independent and it is depending upon hepatitis B for its survival. Morphology. Earlier we said about 22, 27, hepatitis A, B, 42, hepatitis B, but here you get 36 nanometers in size, the spherical quantity, outer core of HBsAg. because it is depending upon its presence, HBsAg. Only hepatitis B surface antigen is giving a protective coat for the hepatitis D virus. So single stranded RNA is present and resembles plant viruses or viral satellite virus, but taxonomically Delta virus. Classified in the new genus Delta virus due to special features. Clinical features, mode of infection is similar to HPV because it depends on that. Co-infection of HPV and HDV transmitted together, presence as acute hepatitis B, ranging from mild to fulminant disease. Superinfection, Delta virus infection occurs in persons already harboring HPV. Usually leads to serious and chronic illness with deterioration of hepatitis B virus. So, it exactly follows the course of hepatitis B. Okay, so HDV is not associated with hepatocellular carcinoma. That we must remember. Again, this is in green. That means hepatitis B is associated with hepatocellular carcinoma, whereas hepatitis B virus per se is not associated with hepatocellular carcinoma. Coming to laboratory diagnosis, detection of viral antigen in liver cell nuclei by immunofluorescence. Okay. In liver cell nuclei only, you can find the viral antigen. Serum, it is rarely present in the serum. And detection of antibodies can be done by ELISA, IgM, 2 to 3 weeks after that. And IgG appears subsequently. Persistence of IgG may be there for years. However, chronic infection, the IgM also may persist. Please remember, this is a condition wherein you may find both IgM and IgG even years together. Now, the delta RNA sequencing, DNA probe for identification of delta particle in circulation, experimental study of which would check is a suitable model. But as far as the exam point of view is concerned, they ask you HPV as a short notes question. That too, 2 marks, not even 4 marks. Because there are better questions that can be asked. So, but for a 2 marks question, you write 4 important points. It is not associated with hepatocellular carcinoma. If it is dependent upon hepatitis B virus, and only the delta antigen sequences can be found out, and rarely the serum antibody can be present, and both IgG and IgM may persist for years. That's all. So, now, epidemiologically, worldwide, spread in endemic areas and non-endemic, there is a difference. In endemic areas like Mediterranean countries, again, I'm sorry about the spelling, Mediterranean is different. Non-percutaneous routes, especially close personal contact. So it is not, HPV means injection, syringe or serum apparatus. But apart from that, the close personal contact also can be responsible in endemic areas. Non-endemic areas, oh, there are too many spelling mistakes. I'm sorry about that. Endemic, only 1 D should be there. Endemic area, non-endemic areas, Northern Europe, North America, move through blood and blood products, common blood examination, failures, or even hemodialysis. Fatality, more in non-endemic areas. Okay. In endemic areas, there is some sort of an immunity, whereas in non-endemic areas, they are not exposed. And so, the fatality is more in non-endemic areas. What is the prophylaxis for hepatitis D viruses? There is no specific prophylaxis for hepatitis D because immunization with HPV is effective as HDV cannot target HPV infection. That means already the hepatitis D is dependent upon hepatitis B virus infection. And hepatitis B you have taken vaccination. So where is the question of the dependent Delta virus coming and affecting you? So proper hepatitis B vaccination not only prevents HPV, but also HDV. So screening blood and blood donors automatically limits blood-borne HDV infection. Now that brings us to the penultimate part, that is HEV. Hepatitis E virus, bulk of acute hepatitis cases, less than up to 50% hepatitis A and B in many developing countries. Okay, so hepatitis E virus. E, NANB, it forms the bulk of non-A, non-B hepatitis, transmitted enterically, so-called enterically transmitted non-A, non-B. In 55 to 56, large epidemic occurred in Delhi during winter, 30,000 affected within 6 weeks. Okay. How? The HEV causes type E hepatitis, endemic and sporadic hepatitis in India. There is a similarity about HEV and HEV. Similar clinically and epidemiologically. Okay, type E hepatitis, earlier mistaken as type A because of the clinical picture. It is occurring just like hepatitis A virus. But serologically and virologically means you are able to demonstrate the HEV antigen. Serologically, the antibodies. There is no evidence serologically and virologically to suggest that it is HEV, but you can say it is HEV. What is the source? Fecal contamination of drinking water and environment. So here in HIV also you get because of contamination only. But here it is a different way and a different virus. Rate of secondary attack, that is what I think differentiates. In household contacts, only 2 to 3%. Whereas hepatitis A, 10 to 20%. So the household contacts infection rate is less in case of HEV than HAV. Coming to clinical features, 2 to 9 weeks, and average 6 weeks is the incubation period. Age, most cases occur in young to middle-aged adults. In HAV, it is more the children group. Those mild to self-limited illness, severity increase with age, low case fatality rate, 1%. So, case fatality rate is also less, 1%, or less than 1%. In pregnant women, clinical severity and high case fatality rate are 20 to 40%, especially in the last trimester. Be very careful about hepatitis E coexisting in pregnancy. Size, shape, and structure is a spherical, non-annular virus, again 30 to 34 nanometers in diameter. Earlier HDV, we thought it as 36 nanometer particle, and again single-stranded RNA genome. There also single-stranded RNA genome. Surface of the virion shows identical indentations or spikes, just like you have seen in hepatitis T virus or C virus. C virus only. Okay, and taxonomically resembles Calici virus, such as Norvac virus, and provisionally classified as Hepatitis or HEPE viridae. Okay, viridae. Coming to the laboratory diagnosis of hepatitis E virus, immune electron microscopy, so direct demonstration of the antigen. Sample is the feces, or even bile at the time of incubation period, or acute phase of illness. Experimental infection, many primates have been tried, and it is a reservoir, unfortunately, pigs, because they are everywhere, and maybe there is a problem. In vitro culture, that is outside the body, you are unable to culture in cell lines. And cloning, the genome is cloned, serotype, only one serotype exists. So are you happy, unhappy, or indifferent? As a microbiologist, I am very happy if there is only one serotype, because it is available to present a good vaccine. ELISA kits IgM and IgG antibody demonstration by ELISA using recombinant and synthetic peptide antigens. So, only one serotype exists, and hepatitis E also is important in the context of epidemiology, clinical presentation, and the differentiation is important. Okay. Now, that brings us to the last one, that is hepatitis G virus. We have seen A, B, C, D, E. What happened to F? F is not there, because once they wanted to name something as F, but they found it that the hepatitis B X, HBX, as a part of hepatitis B antigen or hepatitis B infection. So the word F is, that the letter F is deleted. Now we have the hepatitis G virus. In 1995, two flaviviruses like isolates that are obtained from tamarin monkeys, inoculated with blood from a young surgeon. So the GB are the initials. GB, maybe something like Judge Bernard. Okay, so to commemorate his name, they have put it as GB with acute hepatitis. Surgeon is having acute hepatitis, and they have isolated in a monkey. Okay, so a similar virus is isolated from another human specimen called GBV, ABC respectively. Okay, so GB virus, ABC respectively. But in 1996, again isolated closely resembling GBV-C. As we said, GB virus ABC. In that, the C part is closely resembling, and that is known as hepatitis G virus. Okay, so this is all historical importance only, but better to remember our history, because what we are today is because of our ancestors. Okay, and our children will have the knowledge as a base, and they will be looking to the future depending on our knowledge. So please remember about the surgeon GB, and about the tamarin monkey, and then GBV-ABC, and then how it is named as HGV, that is the GBV-C variety, is very close to hepatitis, and so it's called as hepatitis G virus. Culture, we are unable to grow it in culture outside the human body. Cloning, RNA genome has been cloned. So what about the HGV RNA? It is found in patients with acute or chronic fulminating hepatitis, hemophiliacs, multiple blood transfusion recipients, and people who are receiving hemodialysis, and intravenous drug addicts, and also blood donors. Okay, so hepatitis G virus 2 is a blood-borne virus. That is it. So you must screen before accepting the blood for hepatitis B in the hepatitis group, not only for hepatitis B, hepatitis C, and hepatitis E also, and G also. HG2 is a blood-borne virus, like we see. Higher prevalence in HIV and HCV patients. So, if already the patient is HIV positive or HCV positive, there are higher chances of HGV infection also. Now, whatever you do, the ultimate thing that you want to establish is laboratory diagnosis. So, for diagnosing hepatitis G virus, what are all the things available? So, RT-PCR. It's this RT. Did you get any doubt anytime? RT-PCR is real time. It is real time PCR. here there is one more thing. Reverse transcriptase also is there. We said it is only the hepatitis B, that is a DNA virus, and rest of all are RNA. But usually DNA and make a copy, and then you take an RNA and then subject it to various tests. DNA polymerase, it is there good in hepatitis B. But coming to other viruses, there are RNA. So here, RT may mean reverse transcription also. Because the RNA should be converted to DNA, then only a copy can be passed on. So, at times, where RNA is responsible, you have to convert it to DNA. So, antigen, HCV RNA, get in blood samples of infected patients by RT-PCR, and antibody, by virus-specific antibodies are present in the serum of patients associated with viral clearance and has a protective immunity. Again, I am telling you, if there is an antibody which is protective in nature, that antigen also is very useful. Because if not today, tomorrow, you can produce a vaccine. That is important. Okay, so HGV RNA, you can do a RT-PCR and confirm the diagnosis, and the antibodies are present in the circulation, and with time there is a reduction of the antigen because the antibodies are protective in nature. And what about the role of HGV in hepatitis? It is still not very clear, but we are sure about the existence of hepatitis G virus. But how far it can be, or it can be named as one of the hepatitis causing viruses, that's still doubtful. But majority of the world is suffering from hepatitis B virus infection. So, to just have a quick look at what we have seen in the past two classes, we have seen about hepatitis causing viruses. A heterogeneous group which consists of A, B, C, D, E, and G. A is through the contaminated water sources of milk or food. So hepatitis A, it's a mild infection. You may even get and relapse after some time, lifelong. Or you have a vaccine. And you can use the vaccine, and it is good. Almost 15 to 20 years you are free. About hepatitis A. Hepatitis B is very important because there is so much, and as long as we live as doctors, hepatitis B virus, we must know everything about it. Okay? And it leads to hepatocellular carcinoma, a vaccine preventable cancer. Right? Cancer is something which we don't know. Cancer is painless to start with. And once pain is there, and you can do nothing about it. So, are you not happy that you are able to prevent a cancer by just giving a vaccine? Definitely, hepatitis B virus causing hepatocellular carcinoma can be prevented by taking hepatitis B virus and HPV vaccine. Good. And then we have seen about hepatitis C virus also. And then D, which is a dependent virus on HPV. Again, it can be prevented by proper vaccination against hepatitis B virus. And then we have seen that it is hepatitis B E virus, which is looking like A, probably mistaken. Earlier cases of hepatitis A, and it is because of the contamination of water sources between the fecal and drinking water supply lines. So the sewage lines and the water communicating and water transporting lines are underground. They got mixed up. And within 6 weeks, something like 30,000 cases have come in Calcutta. So that is where we have to find out where we found out about this E virus, that is C virus. And then F, we said it is a part of hepatitis B and HBX. So that's why there is no letter F. And finally, we saw about hepatitis G virus, the role of which we are not sure in hepatitis, but can be diagnosed by RT-PCR and antigen and antibody. Both can be detected. And antibody, virus-specific antibodies are present. And prognostically, once the antibodies are increasing, antigen is decreasing. Definitely, hepatitis is coming to a reduction. And we are happy about the treatment. So, I think that finishes our exchange of information regarding hepatitis viruses. Please remember, hepatitis B is very important. There may be an essay question, and hepatitis A for first question, and hepatitis E can be asked as again a 4-mark question. Hepatitis D can be asked as a 2-mark question. For online assessment, we are giving MCQ questions, multiple choice questions, and a minimum of 15 questions will be prepared for the next online examination. In this topic covered hepatitis G virus. So, hepatitis virus. Okay, not just G. A, B, C, D, E, and G. So thank you all for patient listening. Let us meet again next week with HIV virus. Okay? No. Let us meet again next time with a class on HIV virus, not with HIV. Thank you. Oh, sorry. Okay.